The World Health Organization Pandemic Agreement, finalized in May 2025, aims to enhance global pandemic response. However, its dense language raises concerns about hidden agendas. The United States abstained from final discussions, fueling debate. Key issues include expanded surveillance, mandatory reporting, and the World Health Organization's new authority to declare emergencies. Are these measures truly for global health protection? The World Health Organization Pandemic Agreement, finalized in May 2025, aims to bolster global pandemic response. It mandates expanded surveillance, coordinated resource sharing, and grants World Health Organization authority to declare emergencies. While intended to enhance cooperation, the agreement's complex language hides provisions that warrant scrutiny, raising questions about sovereignty and transparency. The United States' absence from the 2025 pandemic agreement highlights significant concerns. Initially active, the United States advocated for transparency but later withdrew, citing sovereignty issues. Intelligence agencies flagged potential power shifts, leading to reduced engagement and eventual withdrawal. This decision raises questions about the treaty's implications and the United States' stance on global health governance. The pandemic agreement raises sovereignty concerns by allowing World Health Organization officials to declare emergencies without member state approval, mandating compliance with their directives. Article 17 empowers the Director General to unilaterally declare a public health emergency of international concern, triggering mandatory protocols. Nations must comply, facing financial and diplomatic penalties for resistance, sparking debate over power transfer to unelected bureaucrats. The agreement's technical appendices reveal a global surveillance network, officially an early warning system, raising privacy concerns. It mandates cross-border health data sharing and digital tracking solutions. Real-time surveillance hubs and interoperable health certificates are established, with a World Health Organization-controlled database. However, oversight is limited, with vague privacy protections and minimal accountability, risking potential abuse. The pandemic agreement's financial frameworks favor pharmaceutical giants, biotech firms, and digital health platforms linked to World Health Organization leadership. Provisions mandate stockpiling vaccines from authorized suppliers and procuring surveillance tech from approved vendors. The opaque selection criteria raise concerns about potential conflicts of interest, questioning the integrity of these lucrative designations. The pandemic agreement's censorship clauses raise significant concerns. Article 24 mandates combating health misinformation, yet lacks clarity on defining false information. This ambiguity risks stifling legitimate scientific debate and dissenting opinions. World Health Organization approved narratives dominate, with content filtering, removal mandates, and legal penalties enforcing compliance, potentially undermining free speech and critical discourse during health crises. The agreement mandates nations to share biological samples and genetic data with World Health Organization labs, raising concerns about biological sovereignty. Countries must submit novel pathogens within 48 hours, creating centralized repositories with unclear security. The centralized control of genomic data and physical samples, mainly in Western nations, poses questions about access and research, including gain-of-function studies. The agreement's vaccination clauses, while not mandating universal vaccination, establish frameworks that could effectively enforce it. Signatories must implement measures to meet World Health Organization vaccination targets during emergencies. Provisions for health status verification systems threaten freedoms, potentially restricting travel and access for those refusing recommended vaccines, raising significant concerns about individual choice and autonomy. The pandemic agreement grants World Health Organization officials extraordinary powers during emergencies, with vague criteria for relinquishment, risking permanent emergency governance. Article 15 allows indefinite extensions with minimal oversight, suspending democratic processes. History shows temporary powers often become permanent, with initial declarations lasting 6 months, requiring only 3 votes for indefinite extension and no limit on extensions. The pandemic agreement exemplifies how crises can lead to expanded centralized authority. Provisions drafted before 2020 suggest a strategy to use health emergencies as pretexts for governance changes. Critics argue this pattern of problem creation, fear amplification, and public demand facilitates the implementation of pre-planned solutions, raising concerns about potential manipulation of crisis scenarios. China's influence over the World Health Organization raises concerns about its independence. The pandemic agreement mirrors China's health surveillance systems, with provisions favoring Chinese pharmaceutical companies. Key negotiators have ties to Chinese research institutions, suggesting conflicts of interest. China's financial leverage as the World Health Organization's second largest contributor further entrenches this influence, impacting policy directions and technology vendor preferences. The pandemic agreement's architects reveal significant ties to private interests. 6 committee members were senior pharmaceutical executives, now benefiting as authorized suppliers. 4 architects are linked to foundations investing in mandated health technologies. Notably, 8 drafters hold financial stakes in companies set to gain from the agreement, highlighting potential conflicts of interest. The pandemic agreement is the latest step in a historical trend toward centralized global governance. Health crises have historically expanded authority, from medieval quarantine laws to modern biosurveillance. This agreement codifies such control on a global scale, reducing local autonomy and establishing a permanent structure for international health governance. The pandemic agreement's Article 32 grants World Health Organization officials and corporate partners broad immunity during emergencies, removing accountability in national courts. This provision shields World Health Organization actions from legal challenges, even in cases of severe harm. It establishes a World Health Organization-controlled arbitration process, lacking transparency and independent oversight for resolving disputes, affecting individuals' ability to seek justice or compensation. Resistance to the pandemic agreement is growing, with nations questioning its impact on sovereignty and democracy. Public protests in Europe, Asia, and Latin America demand transparency and democratic involvement. Some countries are reviewing the treaty in parliament, while others consider reservations to restrict its domestic influence. Critics of the pandemic agreement highlight its potential links to global population control. The treaty's reproductive health provisions and centralized data systems raise concerns about demographic targeting. Ambiguous language on family planning during emergencies and influential advocates' past support for population reduction fuel these suspicions, suggesting hidden objectives intertwined with climate initiatives. The pandemic agreement's digital infrastructure mandates interoperable health certificates and border screening technologies, raising concerns about global surveillance. Integration with digital IDs, financial networks, and social services could enable a social credit system where compliance with health directives is essential for societal participation. This framework risks transforming public health measures into tools for global control. The pandemic agreement's redefinitions of key terms like pandemic and vaccine expand their scope significantly. Pandemic now includes non-infectious conditions, while vaccine covers broader medical interventions. Public health emergency encompasses potential threats, enabling frequent activation of emergency powers. Misinformation is redefined to stifle dissent, and necessary measures remain vague, allowing for extreme interventions. The pandemic agreement's implications demand scrutiny. Share factual information about its provisions, contact elected representatives for transparency, and support independent journalism. Remember, international agreements need national implementation. Use your voice to influence how these provisions take effect. With 194 World Health Organization member states affected, your awareness and action are crucial in this global governance shift.